So, Saeed, you can start with the introduction. It's
Sure,
8:05 now.
sure, sir.
I
Sure,
mean 9:05 in your, yeah.
sure, sir. Thank you so much, sir. Bismillah Rahman Rahim. Assalamu alaikum. All my respected senior teachers and my dear colleagues. I am Dr. Saeed Nazir from Indus Hospital, Karachi. I welcome to all my seniors and dear colleagues. Almost we have completed our 5 modules regarding the neonatology, and in this time we started our 6th module. And this time we covering the common neurological problems in the newborns. This is today our 3rd session. Last time we covered birth asphyxia and its management. So today, again, we are covering the another most common problem in newborn, which is approach to neonatal seizures and its management as a neurologist perspective. And today, our speaker is Dr. Raman Kumar, and he is FCPS Pediatrics and Fellowship Pediatric Neurology, Khan University Hospital, Karachi, and Assistant Professor, Consultant Pediatrics Neurologist, Section Head Pediatric Development Unit, Jakan National Hospital, Karachi, and Visiting Faculty Center for Autism and Rehabilitation, Training, Sindh, Karachi, and Visiting Faculty, South City Hospital, Karachi, and Visiting Consultant Pediatrics Neurologist, Balochistan Institute of Child Health. Over to you, sir.
Thank you so much for the kind introduction. So I won't be wasting much of the time. So the topic is, I haven't written the neurologist perspective because I want the neonatologist and neurologist to be on the same page as far as neonatal seizures is concerned. So it's one of the, as you said, it's one of the most common presentations in the neonatal intensive care units. So I'll start with the objectives. We'll answer a few questions after this presentation. We might have. So as the questions come along, try to answer in your brain and then see how what the guidelines are. So the first question is the developing brain more susceptible to seizures? So yes. Is the developing brain more vulnerable to injury? So this is another important question. Does neonatal seizures and neonatal epilepsy mean the same thing? What are electrographical seizures and what are clinical seizures, and what to treat, whether to treat electrographical seizures or clinical seizures? Does seizure types have a diagnostic value? Because when I get a lot of calls from the NICU for consults, so I usually don't get the exact semiology. The only thing that a neonatologist or a resident over there or a fellow over there stops after telling us that the child is seizing. What kind of seizures, seizure types? So does it have any diagnostic value? We'll talk about it. Can we manage neonatal seizures without EEG? This is a tough question. We'll try to answer that. What is preferred first line of anti-seizure medication in neonates? And then we'll talk about the second line anti-seizure medication in neonates. Will continuation of anti-seizure medication improve neurodevelopmental outcome? This means to say, how long should we continue the anti-epileptics if we have started in the NICU? So how long should we continue giving it? Can pyridoxine and pyridoxal phosphate be used in any of the seizures? So these are some of the important questions that help us in the management of neonatal seizures. So we'll try to cover them one by one. So seizure susceptibility of a mature or developing brain. So a developing brain is more susceptible to having seizure. A neonate is more susceptible to having a seizure rather than a child. In this regard, we need to figure out the pathology or the normal physiology of the developing brain, why this happens. So there is a shift of balance towards CNS excitation than inhibition. So in older children, so there is less excitation than the excitation seen in the generally, not in state. Generally, of a neonate is more excitable than it is inhibited, because it has to learn a lot, it has to grow, so there is a lot of excitation going on in the brain than inhibition. And developmental receptors modulation and ion channel expression in the neonatal brain is something which is also very, very important. We'll talk about it. So if we take this slide, and so if we see what are the factors that increase the susceptibility of a developing brain compared to an adult brain. So normal brain development, if we talk about a normal brain, if you don't talk about any abnormality in the brain, normal physiological newborn neonate's brain is more susceptible to having excitation or seizures. Why? Because there is paradoxical depolarization action of GABA. So GABA actually is an inhibitory channel, and it increases the chloride influx into the cell, which causes hyperpolarization, which stops seizure. So it is the depolarization that causes the seizure. So, and if we talk about the AMPA and NAMDA receptors, these are excitatory receptors. So they have subunit composition in the neonatal period, which allows more calcium to move in along with the sodium. So a lot of positive ions going into the cell, which causes a lot of excitation in the brain. Then we talk about the glial clearance of glutamate and potassium. So there are less of glial cells, more of neuronal cells, and less of the supporting glial cells. So if there are less glial cells, the glial cells, they do not clear the glutamate in the synapses. So there is a lot of glutamate left over there, which again causes excitation. And then very important point is that the transmission is not just through the synapse. In a newborn period, there is non-synaptic spread of excitation as well. So, a newborn brain is more sensitive to inflammation and hyperthermia as well. So if we talk about brain abnormality, so a newborn brain is more susceptible to any abnormality, be it hypoxic ischemic injury, be it infection, be it any hemorrhage, or any gene mutation, or any abnormal development of the brain. So as we talked about, that there is overexpression of NAMDA and AMPA receptors, which is more permeable to calcium excitation. And there is paradoxical excitation at GABA, and dendritic connections and arborizations, as well as asynaptic, they are underdeveloped. So this is what I'm talking. This is a typical GABA receptor, as you see. So usually in the immature brain, the chloride is coming in through NKCC1. It's sodium potassium 2 chloride channels. So it is more of the chloride is coming in, and when it comes through NKCC1, it is again through GABA receptor, it goes out. But if you see in a mature brain, there is more chloride inside, and through GABA, if you see the arrow through green receptor, the GABA receptor, it's more chloride coming in. Whereas in immature brain, this is the paradoxical excitation through GABA receptor, which is very, very important. And by 3 or 4 months of age, it changes into complete mature GABA receptors. So the crux is that if you try too hard controlling these seizures, you know that these seizures are not being controlled. The reason being the brain has overexcitation. So the question was that we talked about that the newborn brain is the developing brain is more prone to having seizures. It's more in an excitable state, but through certain animal experiments, it's been found that it's less vulnerable to status epilepticus induced injury and the ensuing epileptogenesis. So although it is more prone to having, but as compared to a mature brain, the injury induced by status epilepticus is less. But we need to we don't need to decrease our intensity of treating status epilepticus by this simple statement, because the time is very, very important. It's a developing brain. Any injury to the small injury, even less injury to a developing brain, may have a large impact. So this statement does not mean that we shouldn't be, so newborn brain is less susceptible to injury, we should not be treating it promptly. So we talk about neonatal seizures now. So what kind of neonatal seizures. As we talked about, the question was whether neonatal epilepsy syndromes and neonatal seizure, are they the same thing, or is there any difference between the two? So talking about, as we know, seizures are the most common neurological emergency in the neonatal period, and most seizures are in newborn provoked. So this is previously was used symptomatic when there is stroke, when there is hemorrhagic stroke. So whenever there is a cause identified, we call it acute symptomatic. Now the term has been a little updated. It's acutely provoked seizures. So most of the seizures, like 80-85% of the seizures, are acute. And less than 10%, 10 to 15, less than 15%, they are manifestation of a neonatal epilepsy. So epilepsy, neonatal epilepsy, is very, very different from the acute provoked seizures. So seizures may come basically because of an underlying condition, or it can come as a manifestation of neonatal epilepsy. So there are two things. So if we talk about acutely provoked, HIE is at top, right? So this is the major um, um, factor for the seizures, HIE, and then infections. They are metabolic, vascular. So acutely provoked seizures they cover around 85% of the cases of the seizures, whereas 10 to 15% of seizures have neonatal epilepsy and epilepsy syndromes. Now this is very, very important slide to know. So if we look at this slide, in order to identify epileptic syndromes like Otohara syndrome, like developmental and epileptic encephalopathies. So in such syndromes, we need to know the comorbidities on one side, and we also need to figure out if there is any underlying etiology to because of the connections of the brains. They are not very, very robust connections, and they are not well formed, and the two hemispheres are not very well connected. So you usually do not get, you may get multifocal seizures, but you do not get generalized seizures. So then we talk about whether they are electroclinical or electrographic, and then taking all these things into account, we come to a point, uh, we figure out that this is this typical epilepsy syndrome. So this is a bit more of a pediatric neurologist thing than the neonatologist. When we try to figure out, we see the EGs, we try to figure out which epilepsy syndrome is this, how to go about it. But identification, whether there is an underlying cause or this is epileptic neonatal epilepsy syndrome, it purely is the task of a neonatologist by taking a detailed account of the history and trying to figure out the events and reaching to this point. So talking about epilepsy syndrome, as I just discussed, it's basically, syndrome is anything which has similar findings. If we take like 50 babies with the same kind of seizures, for instance, if we take 50 babies who have epileptic spasms, all of them, and we do the EEGs of all those, and all of those turn out to have burst suppression pattern on EEG, we may consider as pyridoxine-dependent epilepsy, one of the pyridoxine-dependent epilepsies in this regard. So it is one of the one of the epilepsy syndromes. Similar is Otohara syndrome. So there are certain points, the EEG, characteristic EEG finding, characteristic age. When we have characteristic clusters of clinical findings and EEG features, we figure out that this might be an epilepsy syndrome. So just a quick look at how we differentiate epilepsy syndromes. So there is self-limited epilepsies. The previous name for self-limited was benign epilepsies. Now we don't call them benign epilepsies. All of us must be updated with the with the latest nomenclature. So self-limited epilepsies. Then we have DEEs, developmental and epileptic encephalopathies. These are the severe forms of epilepsies. And then we have etiology-specific syndromes, like, as I said, paradox-independent. We have PCDH19. I have a patient of PCDH19. We have Sturge-Weber, gelastics. We have KCNQ2, DEE. So there are certain genetic etiology-specific syndromes. There are self-limited syndromes. And then there is developmental and epileptic encephalopathies. Like in self-limited, we mostly see self-limited neonatal epilepsy, self-limited familial neonatal infantile epilepsy. So various types of epilepsy. So I won't go much in detail. Why is it important for early differentiation, whether it's a provoked or it's a neonatal epilepsy? Because the diagnostic, therapeutic, and the prognostic implications are very, very important in this regard. So this is very, very important part. The question that I asked initially was, can we actually, by the seizures, the seizures that we see, if we see them very, very closely, and we try to categorize them and try to figure out the type of the seizure, can we actually, does it help us to reach a specific diagnosis? So it does, and it also helps us in the management. So there are two ways of one is presentation and the other is seizure type. So if we talk about the seizure presentation, there are three basically presentations of the neonatal seizures. There are three. This is very, very important for us to know. There are clinical only seizures when there is no EEG findings, associated findings. So there is just clinical abnormal movements or abnormal paroxysmal change in the clinical condition, not just the movements. It may be a clinical condition. For instance, apnea. If you don't have any other cause, if there is apnea, so this is one abnormal paroxysmal clinical change. So we may call it, we may consider this as a seizure. And then there is another type, so clinical only, then electroclinical, in which there is electrographic EEG findings and there is clinical findings. And then there are certain seizure types which are electrographic only seizures. So, so these are the seizures that in a critically ill newborn, if we just try to figure out, if we do the EEG, we might see the interictal discharges in the EEG, the findings that a child is, which is also called subclinical. So technically, in newborns, EEG is must. We need to understand that EEG is very, very important in newborns, and we need to get it done. And because most of the movements that a newborn exhibit, and apart from the movement, the conscious state of the child does not allow us to clinically characterize, except for the stereotypic the jitteriness that we say, how to differentiate the jitteriness with the seizure. It is very, very difficult for us to understand. So EEG is must, but we need to understand that EEG is very, very technical stuff. It has to be done by a trained neurologist who is trained to read neonatal EEGs. This is very, very important. So I'll take this up in further slides. This is, I want to talk about electrographic seizures. So there are certain waveforms EEG we see, and you must know that there is an atlas for the MRIs for newborns, and various gestational age children born with various gestational age preterm babies have different myelinations, and a newborn MRI always has to be seen on the atlas. It should not be so. A normal MRI of 36 weeker may be absolutely abnormal normal for a 29, 30 weeker, may be abnormal for 36 weeker. So you have to match it with the compare it with the atlas. So similar, we have EEG atlases. So we have atlas for the different gestational age, and every child has different waveforms. And we see that if the background rhythm, one is, there are two important aspects in the EEGs. One is the background and one is the interictal, which we call as discharges, seizure discharges. So this is important to know. So when you order EEG, you must know. So for me, working here at LNH or in other setups, I feel that EEG is not a utility. Even if we have EEG, we do not get it reported properly, and we cannot make decisions on them. So any EEG which has certain repetitive and evolving patterns are called. I won't go much in detail about it. So it's the typical EEG, but we need to understand one thing, that EEG must have an onset, a discharge must have an onset, evolution, and resolution of an abnormal discharge. So these three things basically, onset, evolution, and resolution of the discharge, we look at those EEGs. So the seizure outcome based on EEG, what do we see basically? So the seizure burden is called, suppose I take 1 hour EEG, if I do EEG for 1 hour, the number of seconds, like for instance, I find in 1 hour, I see 10 seconds, only 10 seconds of abnormal activity. So this is seizure burden. So this is electrographic seizure seconds. So in an EEG, I find 10 seconds of this. So the other thing is seizure frequency. In 1 hour, how many number of seizures occurred regardless of the duration? And then the clinical manifestation, how bad the child was seizing. So out of these three, the most important on which we need to decide the treatment is the seizure burden. The seizure burden, the number of seconds, this one, the seizure burden, electrographic seizure seconds in a given period. So it has to be more than 30 to 60 seconds per hour should be considered as an indication to start treatment. Very, very important for a neurologist to know. Even neonatologists must know. If they have ordered an EEG, they should know the interpretation of EEG as well. At least the basics of this. They should ask the technologist or the neurologist that how many seizure seconds were in the EEG. So if I see on this this is an EEG, and if you see this one, the between the two green lines, this is 1 second. So if we see this, the seizure starts here 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's almost 9-10 seconds of the episode. But if you see in B, so if you see this, the whole thing is the black line. If you see the black and the blue ones, the purple ones, they are continuous. So it is more than like 20 whole pages seizing. So this is considered to be significant, where you need to start the treatment. So important point that I mentioned is the seizure burden, and the seizure burden is defined as the seizure seconds, electrographic seizure seconds in a given period. This is very, very important. You must ask the neurologist whenever you get the EEG done. And there is one very, very important thing as well. So when you start phenobarb on a child, so it may basically electroclinical seizures may become electrographic only. So if there were EEG findings and the seizures, so if you give phenobarb, the seizures may be controlled, the visible seizures, but it may get converted into electrographic. So don't think that if the seizures are stopped, there will be nothing on EEG. So there can be, so there is coupling, uncoupling, or decoupling. Means they were coupled, they were electrographical, clinical and electrographical, and now it has just become the electrographical. Now we talk about the seizure types. So this was the seizure presentation. The seizure presentation comes in 3 forms: clinical only, electroclinical, and then electrographical. So whenever you give a consult, you always use this presentation. And then we talk about the seizure types. So what are the seizure types, and does it actually have diagnostic implication or not? So this I just tried. ILAE, International League Against Epilepsy, in 2017 classified seizures as focal onset, generalized, and unknown onset. But this was for the older children, not for the neonates. So this doesn't fit for the neonate, because we don't talk about onset in children. in neonates. We don't actually pick the onset, how did it start, and there are no generalized seizures in the neonate. So the first thing, whether it is focal or generalized, we don't do it. Second is whether the awareness is intact or impaired, we don't look at this, because a newborn, it is very practically, it is difficult to know the awareness, assess the awareness of a newborn. So this cannot be applied to a newborn. So what we do is we just try to see how did it present. Was it clinical suspicion, or was it electrographical, clinical only, or both, right? So then we do the EEG. That is important. And also AEG is amplitude integrated, or conventional EEG, CEEG, or video EEG, whatever. So if there are seizures with EEG correlate, so they might be electroclinical, and if there is clinical, there may be automatisms, clonic seizures. There is no tonic-clonic, there is just clonic seizures. Then there is spasms, myoclonic to tonic, right? And we may have electrographic only. We may not find any of these. So just a little bit of, we'll see few videos. If you see this newborn, sick-looking child, and let me see if I can play it. Oh, it works. Yeah, so see the chewing movements and a little bit of toe. Oh, I missed it. A little bit of the movement of the toe was also, big toe was also present. Let's see. So this is the commonest type. These are called subtle seizures or automatisms. These are automatisms. Again, the eyes, see, the eyes are moving with these small jerky movement of the eye, automatisms. And again, in this, if you see, again, chewing movements, these are automatisms, right? So automatism is, now if you see this, there is the cyclical movements you will see in this child. And yeah, so that was the cyclical movements that you see. Now what you are seeing is focal seizures, focal clonic seizures. These are the clonic seizures. See the speed. It is very slow, but it is just one hand. And now if you see the same, it is many parts at different. So this is multifocal clonic. These are many different parts. And again, the speed is a little slow. The return of the stiffness is a little slow, right? So these are multifocal clonic seizures. So this is clonic seizure, right? Multifocal. The previous one we saw, and this is generalized. This is tonic seizure. This is myoclonus. See the speed. It's very fast, and the return is not slow. So it is very difficult to differentiate between a clonic and a myoclonic. So remember, myoclonic, they are very fast kind of seizures. And so let me see. So see, these are very sudden, very fiery kind of fast movements. So these are myoclonic movements, right? So this is important to know. These are fast movements. So these are myoclonic seizures. So it is important to know whether it is automatisms, whether it is focal clonic, whether it is multifocal clonic. You can't call it generalized. So if you see them closely, you'll figure out what kind of seizures are these. So just a clinical correlate of, as I said, that they can help us in diagnostics. So automatisms is the seizure in HIE and preterm infants. So you'll find a lot of automatisms. Never wait for those focal fits, and so always these small subtle movements. They can be unilateral, they can be bilateral, asymmetric, or bilateral symmetric, but we don't call them generalized, right? Then we have clonic, as we said. So clonic is pathognomonic of neonatal stroke or cerebral hemorrhage. It's the focal neurological sign, as you say, commonly while examining an older child. So clonic is a small rhythmic movement, and it's not very fast, and the return of the movement is very, very slow. And then the infantile spasms, obviously we know the spasms, these are very, very rare, but they can be seen in inborn error of metabolisms. We did not see this in the video, the spasms. Myoclonic, we saw them. So myoclonic are actually inborn error. They indicate towards inborn error of metabolisms and also prematurity. Tonic are very, very rare. You don't see a child who's tonic is just the posturing kind of a thing. It doesn't, there's no jerky movement. It is just the posturing, and it is very difficult to differentiate whether it is actual posturing or it's a tonic seizure. So this type is seen in DEEs, developmental and epileptic encephalopathy, or genetic neonatal epilepsy. So you usually see tonic. And then there is autonomic IVH and temporal occipital lobe lesions. Apnea is involved in this. And then behavioral arrest is also seen in such. This is very, very important. Sequential seizures. So if a child is having, if you observe a child for 2-3 minutes and he's having a focal seizure, a clonic, focal clonic seizure, and along with some automatisms. So what will you diagnose, whether this is a clonic focal or, so the predominant, we figure out the predominant figure. If a child might have 2-3 types, so we figure out the predominant, the one which is occurring very, very frequently during that 2 minutes. We call that as, so if we have automatism and clonic focal, and both of them are equal, and they're following a sequence, so we call them a sequential seizure. We can't figure out which one is predominant, so we call it sequential seizures. So this is again very, very, and then as we talked about subclinical as well. So this is the thing that I wanted to discuss basically, and basically this is for us, for the where the EEG facility is not available. Even if the EEG facility is available, the expertise to observe the clinical CS, to observe, to read the EEG is not, we don't have that facility. So in that regard, this is something that may help, that if EEG is not available, so it is if experienced personnel is observing, and if you find focal clonic or focal tonic, it's a probable diagnosis of seizure. It's probable. So it's level 2B, it's probable. Whereas if there's any other seizure type, it's a possible. And if there is no, then we don't have insufficient. So basically, on the seizure type, just seeing the seizure type, so the probability of having a seizure is more if it's focal clonic rather than any other type. The other may be possible, but this is probable if someone has a focal clonic seizures. But gold standard is EEG. If we have a conventional EEG, CEG, or amplitude integrated EEG, where 2 leads of the EEG, they just try to give us a raw data of the brain waves. In that scenario, that is also helpful. So we can somehow utilize this for us. Now, there's certain questions to be asked, and I'm quoting this treatment of seizures in the neonate. These are the consensus guidelines recently published in 2022. And this is a task force, ILA task force, which was working on the previously consensus guidelines, and they made some changes, and these are the questions that, so which is the preferred first line anti-seizure medication in neonate? So I would want to bring attention towards one aspect. There is a term called AED, anti-epileptic drugs, and there is anti-seizure medication. There's a difference. The difference is same as an antipyretic to control a symptom, like seizure is a symptom. So if you want to control seizure, you call them anti-seizure medications. But if there is an epilepsy and you're using the drugs for epilepsy, they are called anti-epileptic drugs. So in this scenario, if a child comes to us with a seizure disorder, so what is the preferred first line ASM in neonate with seizures requiring pharmacological treatment. So these are basically all those seizures that are electrographically confirmed. We're not talking about just seeing a seizure clinically. So this study was this was basically they collected around 46, reviewed 46 researches on this, and finally they found 11 which were relevant, and out of them they found 2 randomized control trials. So they found one randomized control trial between phenobarb and phenytoin. So there was no difference between the seizure control between the 2 medications based on the efficacy, but obviously phenobarb was superior in terms of the safety. So there was no difference in efficacy between phenobarb and phenytoin as first in this study, which were randomized control. But they did randomized control in phenobarb versus levetiracetam, where there's a marked difference, and phenobarb was way superior to levetiracetam. So the concept of seeing a lot of levetiracetam being used as a first-line anti-seizure medication, so this proves that this is not. So the consensus statement is also very very strong in this regard, that in neonates with seizure requiring anti-seizure, phenobarb should be the first line. Yes, this is nothing, no doubts about it. And then phenobarb should be the first line regardless of etiology, whether it's HIE or any other form. So you don't need to worry about it, about the etiology, and it should be the first line. But if you suspect channelopathies, so how do you suspect if there is a strong family history in a neonatal period, if there was a child in a family, neonate in a family who had and who has been diagnosed with some kind of SCN1A or 1B kind of sodium channels, or even KCN potassium channel pathies. So the first line should be a sodium channel blocker, in which so sodium channel blocker is phenytoin. So phenytoin is a sodium channel blocker, so is carbamazepine and oxcarbamazepine, right? And lacosamide and lamotrigine. So I remember them as the most oldest of the anti-seizure medication was phenytoin, the most prototype, and then the carba and oxcarba, and then the 2 L's, lamotrigine and lacosamide. These are all sodium channel blockers. What is the preferred second line ASM units? Regardless cessation, regarding cessation of seizures and adverse effects. So 43 studies were found. There were 3 RCTs, 22 were shortlisted, and phenobarb versus phenytoin, not much of difference. Phenobarb and levetiracetam, there was in terms of percentage, but statistically there was no difference between levi and phenobarb as a second line. And lidocaine midazolam was also, and there was statistically there was no difference between the two. So in neonate, the consensus statement was in neonates with seizures not responding to first-line anti-seizure medication, phenytoin, levi, midazolam, or lidocaine may be used as second line. So all 4 of the, irrespective of the cause. But if channelopathy is suspected, sodium channel blocker should be used as a second line. So one thing I like to tell you about sodium channel blockers here is that channelopathy can be a gain of function mutation and a loss of function mutation. So it may be a door which is tightly shut, or it may be a door which is loose. So you don't actually know until you give a sodium channel blocker. So if a door is tightly shut and you give sodium channel blocker and block it further, so you may worsen the seizures may worsen. So sometimes sodium channel blockers we are using as a, we are not using it, but we have a very close eye on how the child newborn is responding to it, and we may actually this be a diagnostic thing for us. So in a neonate with cardiac disorder, levetiracetam is definitely preferred due to its low side effects. So this is important. Will continuation of anti-seizure medication improve neurodevelopment outcome? So suppose if we see if there is a baby who has HIE, and we are discharging on 12th day of life, and the seizures started 2nd, 3rd day of life, and now he's seizure free. You can't see the seizures for last 3-4 days, seizure free on phenobarbital maintenance doses. So are we sending the child on phenobarbital, or are we discontinuing the medication? So if we continue it for 1 month, 3 months, 7 months, 6 months, so is it going to have any good outcome on it? So we found 17 studies, and there were 3 that were shortlisted. So very little data was available on this. So the consensus statement was basically on the Delphi protocol based on the agreement rather than the studies. So following cessation of acute symptomatic seizures, which is provoked seizures, electroclinical or electrographic, both. So in both electroclinical and electrographic, in both there is the EEG finding, right? So the cessation has to be EEG, a clear EEG as well, and the clinical cessation of the seizures. Without any evidence of obviously epilepsy, we ruled it out, and should be anti-epileptic medication should be discontinued before discharge home, regardless of MRI findings or EEG findings. EEG findings in terms of the background rhythm, not in terms of the seizure burden that we discussed. So if there are still EEG findings, we can't discharge. So we have to stop. We have to treat the EEG as well. So it's not just treating the clinical seizures. We need to treat the EEG. So again, the availability of the EEG is very it's phenomenal. It's used, and it's in neonatal seizures, and we actually lack this facility a lot, and we are working without this. So the question is a reduction of electroclinical or electrographic only seizure burden in neonate associated with improved outcome? This is actually trying to say that if we do not treat EEG, if we just treat the clinical and not treat so is there any difference in the neurodevelopment outcome? So they found 80 studies, and there were 2 randomized controlled trials out of 10 that they found. So so what they did was basically they took moderate to severe HIE patients, and they did EEG on everyone. And there were certain group of children in which there were clinical only seizures and there were no EEG findings, and there were a group where there were EEG findings as well as clinical findings. So the seizure burden was basically same, but the long-term outcome at 18-24 months was better for electroclinical group, which was treated. So you need to treat EEG in order to have a better outcome as well. Not just the child, not just the seizure, but the electrographic seizures as well. So treating neonatal seizure, including electrographic only seizures, to achieve a lower seizure burden may be associated with improved outcome. So if you treat EEG, so most of the times, if we just look at our practices, including the neurology practices that we do, is we don't discharge a child without seeing the EEG. We just decide whether the seizures have stopped or not. As we earlier figure out that phenobar may cause decoupling. It may stop the clinical seizures, but it may have a electrographical seizures. So it is very important for us to have such facilities in which we are trained enough to see the EEGs of the neonates. Another important question: should pyridoxine be given or not? Is it any seizure medication? Are we supposed to give it or not? So we found certain studies, 8 studies. There were no randomized controlled trial. So there are certain genetic conditions which are associated with B6 dependent epilepsy. ALDH7A1, I have one patient, and it responds very well to vitamin B6. So the treatment is to be, in order to figure out, obviously you won't get the genetic testing as very early, but you need to decide based on you can't just blindly choose it. So EEG finding is usually burst suppression, and the clinical jerks are usually myoclonic, and they're also sometimes spasms as well. So if you have electrical and clinical clusters fitting into this syndrome, then you have to at least give for 3 to 5 days before concluding that it's effective or not. So 3 days you have to continue, and apnea should always be considered as whenever you are giving pyridoxine So a trial of pyridoxine should be attempted in neonates presenting with clinical features. Clinical, as I said, myoclonus or epileptic spasms, or EEG characteristics suggestive of vitamin B6 deficiency. A neonate with seizure unresponsive to second line without an unidentified etiology. So other recommendations are, this is very important indication that a standardized treatment pathway for the management of neonatal seizures should be available in each neonatal unit. I would strongly recommend a neonatal task force, a national neonatal task force, which should contain both the neurologist and the neonatologist, and we should make a guideline for how to go about it, and there should be a standard practice in all the NICUs around. And obviously, the parents of a neonate should be informed about the treatment options and rest. So these are the, if you get the presentation, so you'll know the doses. It's about the dosaging of the anti-epileptic medications that we use, and a little bit of their side effects. And I won't go into the detail. This is a little bit a brief account of status epilepticus in neonates. So we do not have clear-cut guidelines regarding the status epilepticus in neonates. What we have agreed upon is the definition of status is the same. So they have put forward two timelines. So one is 5 minutes and one is 30 minutes. So 5 minutes, after 5 minutes, we say that the fit is being prolonged, and after 30 minutes, we say that the injury has started. So it is always recommended that whenever T1 hits, we start managing a child. So in 5 minutes, we start doing it. So we in neonates, we try to treat the treatable causes like hypoglycemia, electrolyte imbalance, whatever we can do it quickly. If it's not responding, phenobarb is the first choice. And then the second line, levetiracetam, we usually use. 40 mg per kg is the loading dose in neonates, basically. And then if it is not responding, we call it refractory, and midazolam infusion needs to be started. So the important thing is that whenever we start midazolam infusion, it has to be monitored by the continuous EEG monitoring, because when burst suppression pattern is achieved, so you don't know whether without EEG, you don't know when to stop it, how to go down on midazolam, how to. So clinical seizure is, as we said, in neonates, it's very tricky to pick the neonatal, because most of them, they are still having electrographic seizures. So EEG continuous monitoring is again very, very important. So I think I'm done. I'll be more than happy to take questions. Thank you very much.
Thank you so much, sir. It was a very informative presentation and on very common topic. So here's a few questions. For how long graphically seizures appear in EEG as the patient's seizures has subsides?
So if I understood well this question, that this is asking me, the question is asking me about that if clinical has stopped, when do we expect that the EEG findings will disappear? We can't predict it.
Okay.
We can't predict it. So there is no prediction that we can. Yeah.
Without clinical, right, sir. Another question is, can we use diazepam for acute seizures as its side effect is respiratory depression?
No, so we use phenobarb. We choose phenobarb in older children. We use diazepam and even midazolam. So in order to, but the thing is, obviously, you have to make sense when you're doing it. If a child, if the airway is in your hands and the respiratory depression is to be tackled nicely and promptly, then you can use if there is if it's not controlled by the phenobarbital.
Right, sir. Another question is,
Raman, yeah, 1 minute, say, Raman, my question is, thank you very much for your nice presentation. My question is that you said the second line, everything is the same, and you include lidocaine also.
Yes.
So if the baby is inpatient, the lidocaine is the last medicine we are using, because it has side effects. There's a lot of other things. I mean, we cannot, recommend lidocaine. Yes, the phenytoin or the midazolam or these things we can use, but the lidocaine to include in the same group. Can you comment on that and elaborate?
Yeah,
on
sure,
that?
sir. Sir, I have never used it. You are absolutely right. I would never dare to do it. But I was just talking about the consensus guidelines that they have reached on the agreement, the International League Against Epilepsy for the Neonatal Task Force. They have recommended it, and still there are 3 other choices. So if I have 3 other choices, I may end up on the 3rd choice. I will not go for the 4th choice.
Yeah,
so
exactly.
Absolutely right.
Okay, thank you, Ram. Thank you. Go ahead, Said.
Yes, sir. Yes, sir. Sir, in those setup where phenobarbital is in oral form, can we use in patient with active seizures or give another IV anticonvulsants?
No. So the IV and oral cannot be treated as same phenobarb because of its pharmacodynamics and kinetics. So we cannot replace oral with IV. So yes, if you do not have phenobarbital, phenytoin is another, as we saw in that randomized control trial, which was comparing phenytoin with phenobarb. So you may use phenytoin if phenobarb is not available.
Right, sir. Another question, sir. Is there any criteria for duration, cut off when to stop anticonvulsant if seizures are controlled, but any duration?
So if seizures are clinically controlled and you have seen the EEG, which is also normal, there are no seizures in the EEG. So you may actually discontinue. You have to discontinue. There is no role of continuing phenobarb from the neonatal units unless you're not sure about the electrographical seizures, or you want to. That is the only thing, that if you can't get the EEG done, so that is the only limitation for it.
Sir, is there continue इस क्वेश्चन के हिसाब से करूँ मैं कि is there any duration like हम जनरल पीरियड्स में जो है वो in Nelson it was mentioned कि if child is seizures free since last 2 years and EEG is also normal, then we can stop anticonvulsants. So like that, any
No.
duration
No.
in
No, so let me be very, very clear about the consensus statement that when you are discharging, there was a seizure in the neonatal unit, a child having a seizure, you did the EEG, you treated it, there are no clinical seizures, and then the EEG is fine. Both the electrographical and clinical seizures are gone. You stop it right there. You don't need to continue ASM. It does not have any long-term good neurological impact, or giving it for 2 years does not improve the neurology. It might actually, sometimes it might actually deteriorate the cognition of the child or development of the child. So it is very, very clear fact. Even MRI findings, I mentioned MRI findings. Suppose you have a child, 3rd day of life, you did the MRI is really bad, but seizures are stopped and EEG is clear. Send home without EEG, without the anti-seizure medication. This is very, very clear.
Right, sir. How frequently we check pheno drug level if baby is on phenobarbital?
Yeah, very good question. This is very, very good question. This was not in the not mentioned in the guidelines, but seeing phenobarbital, which has a longer half-life, it takes time to establish blood levels in the. So it is not a wise idea to do it in 1 week or weekly. So at least 6 weeks time you can get the achieved levels. Or if clinically you find the child is very, very drowsy and is not very active, and clinical, if you figure out that the levels may be increased, you may do it early, but in practice we do it like 6 weeks minimum.
Right, sir. In those setups where the lab facility is not available, like drug levels, so do we use first line as a LARES? Because
No.
needs Acha.
No, this is not the reason if you don't have a phenobarbital, because elsewhere levetiracetam is also being seen in the blood, can be measured in the blood. We don't have it, but we use it very frequently. So not having the capacity to check the levels is not the excuse to switch it with any other anti-epileptics. You can still use it and keep an eye clinically on the side effects of the phenobarbital.
Right, sir. Another question, sir. Is there any role of EEG in neonates who have seizures secondary to infections or electrolyte imbalance as a cause?
Yes, absolutely, yes. So as I said, any sick child. So you might not be seeing clinical seizures, but electrographically there might be seizures. There are many children who are electrographic only seizures. They're not clinical seizures. So with any sick child, EEG must be done. Yes.
Right, sir. Another question, sir. Any specific lab to rule out the pyridoxine epilepsy in newborns?
Sorry?
Any specific lab to rule out pyridoxine epilepsy in neonates?
Yes, in urine we check some levels, but I'm not really right now. I'm not really very sure of those. But we do in urine, but it's not available in our part of the world.
Achha, right, sir. Can we use diazepam infusion in those seizures which are not controlled, even on second line, just like in HIE?
So basically, we can use, but we use midazolam infusion more, and then phenobarbital infusion can also be used in such settings. But usually, midazolam is the preferred infusion.
Right. Can we use magnesium sulfate in case of seizures in HIE, which are not controlled
No.
with pheno and Lares?
No, I did not come across any such indication with ILAE doesn't recommend this. There's no indication.
Raman, just 1 minute, Said. Raman, this is, of course, ILAE is from the United States, the League Against Epilepsy, but magnesium sulfate, if you don't have any option, and you know we are living in the resource limited country, so maybe in Karachi, where Liaquat National, you have much more resources than other places. Magnesium sulfate, the only problem is with the magnesium sulfate is that it can cause some side effect, but it can control the seizures also. So I think we cannot say outright that the magnesium sulfate we shouldn't use. But if you don't have any other option, especially in the cases of HIE, HIE, the hypoxic ischemic encephalopathy, magnesium sulfate help in reducing the brain injury also. So this is my thing. I think other colleagues, what they said about Maqbul has to say something. So Maqbul, go ahead.
I take that, sir. I take that. I agree. If this is a common practice, I take that. Thank you.
Yeah.
So one last question. Does the pyridoxine help in seizures, and how long we continue in neonates?
So pyridoxine does only help in genetic epilepsies which are related to pyridoxine pathway, and there are 5 or 6 epilepsy syndromes, and you take 3 days of clinical trial, 500 mg per day, in order to figure out if it's working or not. If it's not working, then you stop it.
Right, sir. Sir Maqbul is want to say something. Ji, sir.
Hey, Assalamualaikum.
Sir.
Dr. Raman, I don't know if you remember me.
Sir, I don't know if you remember me, sir.
I remember you very well. And I must congratulate
That's an honor.
that you have evolved into a fine neurologist now, mashallah, and leading the way in not only in Liaquat National, but other hospitals in Karachi. So congratulations.
Thank you very much, sir. Thank you so much.
And very well presented.
Means a lot, sir.
Summarize it in 1 hour. I know it's a long topic which cannot be dealt with in 1 hour. You need hours and hours to elaborate on these things so very well. I just have 2 comments. You suggested that every country should have their pathway of controlling seizures or not. My question is, now we have this international guidelines, and I know, there is some controversy on some of the medications and whatnot. Why not start with this as a stepping stone, and they just, keep building on it? What is your
Sir, I completely agree, but I have a confession to make that during my basic training of pediatric neurology, I got very little chance of reading neonatal EEGs. So I would strongly recommend that instead of just following those, we should be our neonatologist or neurologist should further choose neonatal neurology as a field. Till then, we may make a little adjustments and we may start using these guidelines. But I don't think that we are capable enough. Our technologists, like for instance, if I tell you that there are 19 leads in the conventional EEG and a head size of 35 centimeter, and if a newborn preterm with a head size of 30 centimeters, now you need to fit in those leads, and this is not the neurologist doesn't do it, it's the technologist, the EEG technologist that does it through a specific 10-20 ratio placement of the leads on the head of the neonate. It's a very technical thing. So right now it's not just that you don't have EEG, you may buy EEG machine, it's not that it's 5 million rupees, you may buy EEG machines and place them all over the NICUs, but it's basically the expertise of using those machines, the technologists that need to be trained, the neonatologists, like most of the neonatologists are very well trained to use echocardiography. So the same goes with electroencephalogram.
Assalamu alaikum. I have a few questions. Regarding that CFM and the EEG you were talking about, is there any difference of efficacy of CFM and EEG?
Yes. So basically, EEG is the conventional EEG that we do. It is more so it picks up the voltage difference between 2 points, and the amplitude integrated EEG that we do is basically it's the all the 19 leads, they are converted into just 2 leads, and they give you a they just tell you through amplitude. The waveform that we need to see is through the conventional EEG, and that too has to be long. It doesn't settle in the conventional EEG that we do here is 20 minutes, 25 minutes, we put in the leads. It has to be, in order to see the seizure burden, which is 30 to 60 seconds of seizures activity in the EEG, it has to be at least 1 hour long.
Yeah,
so we cannot rely on
Dr. Obed, AEG is just a acute thing. It's only the 2-channel, or sometimes
Yes.
People are putting 3 channels, but
Yes.
the full AEG is the 20 channel, or sometimes using 70 channels. So you get the full picture of the brain. So that's why, by the way, in AEG, you can miss something, a subtle seizures, you can, that's why always, let's say in the patient of HIE, we put on the AEG, but later on, when the patient is stable, we finish cooling, we do the EEG also, whether the baby get the seizures or not the seizure, we do the EEG on all those babies.
Okay, one more question regarding pheno level. We used to do pheno level before the next dose. If you give 1 dose before going the regular dose, we used to do it. And usually in late preterm, 30-34 weekers, it always come high, and we used to hold the pheno level before giving the next dose. So you said that we need to go do pheno level after 1 week. And my experience is that always come high above the normal limit. So there's a contradiction.
No, so never we do phenobarbital levels before we don't go for the trough level. It's 72 hours half-life, so you don't have a trough in that. So it goes down, so you don't never ever. Valproic acid level, you always do trough levels. Carbamazepine levels, you do trough levels. For phenobarb, you can do it any day, any period of the time, and it won't mess up your results, because the half-life is such that it stays in the in the system. So it is not the right practice to do it before the previous dose. And since doing it very frequently, one more thing that we need to understand is the interactions of the drug. So phenobarbital and phenytoin, they're always interacting. Sometimes both of them are being given in the neonatal. So there is a drug interaction checker. If you search Google and you write drug interaction checker, there are so many calculators, checkers that you will get, and you just put in the multiple anti-epileptics in that, and you will find out that certain anti-epileptics are not working together. So I kind of disagree with the trough levels in phenobarbital.
Anyway, so if we are doing it, it comes above the normal limit. So the blood all has the drug that is above the normal limit. Is logical to give the next dose?
No, we try to reduce the dose. And it's not to do with the next dose. The level that is come now that you have seen, it is inside the system. The phenobarb is inside for 72 hours. Any medication which has 12-hour half-life, that if you give it after 12 hours, it comes down. That is a trough. You don't get a trough in phenobarb. So if you get at any point, you get the high levels, you need to decrease the dose. Sometimes you need to stop it. If clinically indicated, you need to abruptly stop it.
Okay, thank you.
Right, sir. Any comment from Professor Khalid, sir? Can you hear us?
Yes, I can hear you. Thank you very much. Lovely presentation. And I think the point which is being made is very important, that EEG is so important in neonatal seizures. And you need to develop expertise in not only doing it, but also reading it. And that is deficient in Pakistan. So the question is, if you don't have EEG, when will you stop phenobarbital if clinically the seizures have been controlled?
So perfect. So, sir, the question that you are asking is actually what we do, because we don't actually discharge every neonate from the NICU, getting the EEG and discharging them. So what we do is basically we do it for 3 months. We give it initially for 3 months. We continue it 3 months. Some literature says that if you don't have EEG, give it for 1 month, reevaluate. If you can get the EEG right there, and if you see the findings, get the findings there. So it is 3 months and then reevaluation at 6 months.
Why do you choose 3 months and 6 months? If the baby has clinically stopped seizures and you don't have EEG, what is the rationale between choosing 1 month or 3 months or 6 months?
Sir, there is technically there is nothing. It is just it differs from various centers to centers. Some are doing it they reevaluate after 1 month, get the EEG done if they have the EEG facility. If we don't have the EEG facility, the only indicator is we see the development of the child. So any child who is having electrographical seizures will not attain a normal developmental milestones. So if you don't have EEG, very crude and method of deciding upon it. So 1 month you can't really decide. At least 3 months neck holding, you can see that if the clinical seizures were not there, you see a 3-month-old child in your clinic is doing fine, he's thriving well, his development milestones are normal. You may decide that okay, we'll taper it off if we don't have the EEG. If we have the EEG facility, then we'll decide on that.
I agree with you, but it's a clinical acumen which makes you decide when to stop phenobarbital, because phenobarbital by itself, long-term phenobarbital is not very good for a developing brain.
Absolutely, sir. Absolutely, we need to avoid it. We need to avoid giving it extra.
And to add to this, sir and Raman, the problem with that who is monitoring, because in 3 months the kid is gaining weight and nobody adjusting the dose. So that's another problem, that we are giving phenobarb which is suboptimal. So most of the time, if we have all the facilities here in the US, but the thing is that if we don't have, I think they should stop it before discharge, and frequent follow-up with the pediatrician and with the neurologist, and to see that how the baby is doing, because most of those kids are doing fine actually. And as Professor Hutt said, it's very much right that if we discharge for 3 months on the phenobarb, itself cause problem. And my point is that if the baby is gaining weight and we are not adjusting the dose, then this is the suboptimal dose, which is again not a right way to do it. But I know that you it's not you to answer. But anyway, this is a very good point to be discussed among your team of neurologists. Okay.
Sir, I think this should be taken up as a research project. This is out of this discussion, it comes out as a very strong research project that we should see the outcome, because if I see a 3 month, if I have discharged a neonate from NICU, stopping the phenobarbital, and then 3 months of age or 6 months of age, he starts having proper seizures and he's developmentally delayed. So retrospective looking at my decision, I'll be a little, so I don't know how many kids would do like this because there's no research. So we can take this up as a very good research project, and all those who are kids who we can follow them with neurological outcomes and the seizures later in life, whose phenobarb was stopped without EEG.
Okay, Saeed, I think this is the time now. Thank you, Raman, from my side. Thank you very much. A very nice discussion.
One last question.
One last
question. Raman, I think you're right to have a research project, but the question is, let us say you stopped phenobarbital and then in 3 months' time you saw the baby or had an EEG and the baby was, or the baby was not developing normally. How would you relate that it was secondary to not stopping phenobarbital? It is going to be a very difficult research question to answer.
Yeah, so a lot of ethical concerns, and but to be very honest, my practice is that if I don't get the EEG on discharge, I continue 3 months. I see the baby with for the developmental milestones. I be sure that everything is fine. Then I stop it. I don't stop it right there. So
I think it's a very pragmatic approach. I like that. I think I accept that. But I'm just raising that as a question. But I accept.
Sir, it's an ethical concern. It's a big ethical concern.
Right, sir.
Thank you. Lovely presentation. Thank you.
Thank you so much.
Thank you so much, Dr. Raman. I'm very thankful to you on the behalf of our team, Neonatal Task Force Pakistan. It was really very wonderful presentation on a very common topic. So once again, thank you so much. And inshallah, next week we will continue this session again on same day, and our topic will be brain injuries in preterm babies, and our speaker will be Dr. Afshan Khattak. So inshallah, we'll meet you all soon next week. Allah Hafiz. Thank you. Thank you.
Thank you so much.
Allah Hafiz. Allah Hafiz.